Fertility and Genetics with Dr. Serena H. Chen. She's going to join me in just a moment. You know, last week we started to reach out to all of our followers and ask the questions. What are you curious about as it relates to genetics? Dr. Chen is doing a project with a very well-known company. I'll let her talk about what the project is. And we wanted to take the opportunity to answer some of those questions actually today that everybody came up with. So sometimes we ask questions and Casey, who's my amazing digital media manager. Hey, Serena.
Hi,
hello.
how are you?
I am doing great. How are you? It's
Really
so good to
good.
see you.
Really good.
Yes. Okay. Well, I'm excited for this conversation. You know, last week, Casey reached out to our community for us to solicit some questions. Make sure you turn down your computer so you don't hear me twice. And we've compiled those questions in preparation for your talk. So I think the first thing that I want you to do is kind of introduce that project for what you and the company that you're working with is embarking on, and why you were soliciting kind of the audience's feedback on what kinds of questions that they have around genetics and fertility.
Yeah,
Can you give us a little background?
The American Society for Reproductive Medicine is meeting next in 2 weeks, right? On I think the 19th. Yes, so it's exactly 2 weeks. And it's the largest reproductive medicine meeting in the world. So the largest gathering of people like us who are freezing eggs and making babies and in test tubes and doing things like that. And genetic knowledge in this space, just like every other space, is exploding like crazy.
Mm-hmm.
And just like drinking from the fire hose, like it's hard to keep up even for people who are
Sure.
experts in this area. And so I'm working with Invitae, with one of the big genetics companies in this space, and there are many, and these guys do a lot of different things. Like they test pregnancies, they test babies, they test moms, they test intended parents, they test embryos, and we're doing a presentation on just that, the genetic overwhelm. And
it's overwhelmed for doctors and for patients. I mean, I think that we need to really acknowledge that, right? Because
Absolutely.
Years ago, we interviewed you and Dr. John Norian and some others in this space. And we said, what are the two things that you wish you learned in medical school? And unilaterally, even though we interviewed you all separately, you all said genetics and nutrition.
Yeah. And it's still the case.
It's still the case, right? But it's hard to catch up. I mean, when you have people who got PhDs in genetics, right? They completed a very long program in doing that. You had a very long path, you know, just to getting through fellowship. What do you think is one of the missing links when it comes to that provider confidence and that patient education as well? Because it's missing on both sides.
Not only did we learn very primitive and very minimal amounts of genetics, no matter how expert we were in medical school or residency or fellowship, you know, if you finish that last week, you're not up to date this week.
Right. It's that fast. Yeah.
Yeah, it really is super fast, and which is very exciting. And I think ultimately will be really good for our ability to take care of patients and our ability to prevent disease and to promote health and wellness, and, you know, hopefully end suffering, and just have more insights into human biology and things like that. But it is a little bit overwhelming because obviously we want to do the best for our patients. So this is like a dialogue seminar that Invitae put together, and I'm talking with some, you know, genetic experts, and we're having a dialogue about how do we do the right thing by our patients? How do we address those things? How do we support providers? And, you know, I wanted to hear, you know, from our audience about, like, you know, how, like, what are the gaps that we're missing when you go to see your doctor and your doctor starts talking genetics? Like, I feel like sometimes I'm like in that Charlie Brown thing where wah, wah, wah,
right,
and my patient looks at me and just is like Dr. Chen, I don't know why you're talking with me about this, because you're not making sense. How does this relate to me? How is this helping me? And sometimes I like to pride myself on being clear in my communication, but I get these questions all the time, and it's clear that I'm not totally clear.
So Lauren brings up a really good point, although it's through a disappointment. And I hear this one, Lauren, over and over and over again. She was disappointed that her 5-day blastocyst, genetically normal, and still resulted in a blighted ovum miscarriage.
So yeah, and I cannot tell you, Lauren, how, I mean, you know how hard it is for you, and I can't possibly put myself in your shoes, but I will tell you, your doctor is super, super disappointed also, and the lab is super disappointed, and everybody is really, really frustrated about this.
Right.
And that's why we're putting so much energy into trying to answer that question. Obviously, what we've done is we found out a lot of information about your embryo, but we haven't found all the information about your embryo. We think we found like 60 to 70% of what we need to get you a baby, and the 30 to 40% that we don't know is the part that results in stuff like this.
Mm-hmm. Can you actually define what a blighted ovum is? Because a blighted ovum miscarriage is not a common term.
It's like an imprecise term, but it basically, like, blighted, what does blighted mean? But basically what we mean is like you're pregnant, we can see a sac, and we can't see anything else. We don't see fetal parts inside that gestational sac inside your uterus. And for some reason, like some historic reason, and it would be interesting to try to find out why, but it's called a blighted ovum or a missed AB or an empty sac. And this usually happens in the first trimester between 6 to 8 weeks. And it's typically due to trisomy, an extra chromosome, but obviously Lauren didn't have trisomy. She had normal chromosomes. And so this was due to some other, I think, intrinsic genetic embryonic issue.
So isn't this the hope, though, of non-invasive PGT? Maybe that's a wrong question to ask you. I mean, we know a partner who's really worked on this.
Non-invasive PGT is going to be a game changer when we get to it, but it is very, very complicated, very, very difficult. And I've talked with a lot of companies about it, and in fact worked on some studies about it, and it's extremely challenging for reasons that you might not think about. And but the idea is, the media around the embryo, it's alive, it's doing all these cool things, it's metabolizing, it's doing, like, in fact, a gazillion things, because it's growing so rapidly, so much more rapidly than at any other point in your life. And so awesome. It's making DNA, it's changing DNA, it's making proteins, it's metabolizing sugar, amino acids, all kinds of, there's cytokines in there, there's all kinds of molecules that are being made and utilized and digested and put out there. And if we could analyze all that juice around that embryo, just like the embryo is growing in its little droplet of fluid, and you just take that magic fluid and say, what's in there? What can that fluid tell us about what's going on with that embryo? We don't even have to touch the embryo. We're essentially taking the waste products in the environment from around the embryo. Like,
which would be
doing
amazing.
Like a breathalyzer on the embryo and saying, well, you've had a few too many drinks and you should not drive.
Right.
And so, that would be revolutionary. And people have been working on this, since the 1990s, because that's how early I remember, like, I saw the first study we participated in. And it's so difficult because every little droplet is a little bit different. We try to make all the droplets the same, and our droplets are different than other lab droplets. So then, the scientists come in, they're like, we want every single droplet to be the same, and we want you to move the embryo around.
Well, that's really, and that's really the hope, though, of it, right? Because that is what's happening, though, with biopsies today, is you biopsy one part of an embryo, you're not biopsying the entire embryo.
Right.
So,
and this is like a picture of the whole embryo. Exactly.
Right. So it's just to really speak to, also to just validate what Lauren's feeling. She's feeling nervous to use her other normal.
No,
because
don't feel that way. Don't feel that way. It's you're going to get there, Lauren. You had a normal embryo, you had implantation. That just means the only thing between you and a baby is like you just give up too soon. So please don't do that, please.
Okay, don't give up, Lauren. Don't give up. Yeah, I know, but I know the feeling of the nerves because I have 5 embryos that are still frozen, which feels like a lot when, I talk to somebody like Lauren who has 1, and yet I'm nervous too because I want to make sure everything's perfect. So I give my next go like a perfect chance, and there is no perfect. And and statistically, we just have to keep trying. I think that is great advice. And I'm E. Carol, or I'm Ed Carol, however I say your handle. Yes, we will save this into IGTV. We always save all of our episodes, all of our chats that are live do get saved in IGTV. So you can check it out later. When Instagram added the ability to do a title beforehand, it was so helpful so people know the context of the conversation. That was a really good addition. It's so good seeing people jump on. We're talking about fertility and genetics. This is a tough conversation because there's a lot that we don't know.
Alice, we got so many great questions. I'm thinking we're going to have 2 episodes on this.
Yeah. Lauren, I totally understand.
Everybody.
We're not. Yeah. Lauren, I understand. She says she's got 2 more. She just doesn't want to set herself up for failure. I get it. I mean, we try to temper expectations while we want you to be super hopeful and
so
realistic. And it's so hard, that
balancing
juggle.
Act.
Yeah. Total juggle.
Lauren, you got to keep your head in the game. So, you got to keep your head in the game because you are going to get there, and we can't tell you which embryo.
Are there
this batch, but it's going to happen.
Are there any genetics that leave her more predisposed to a blighted ovum? I have a friend who had a blighted ovum as well. And is there any genetics that go into that?
It would be really rare things. One thing that might provide reassurance to you, Lauren, is to get karyotypes done on both you and your husband. And usually, even though you're at an IVF program, you've done a lot of genetic testing already. Most people don't do karyotypes on everybody. And I think if you're feeling really, really insecure about a normal PGT normal embryo resulting in a blighted ovum, it would be nice to get testing on the pregnancy tissue, but maybe also get the karyotypes or check the chromosomes on you and your husband. Talk to your
So what does that do, Serena? So let's back up a second and be really defining what's karyotype.
Your own chromosome. So theoretically, Alice and I are both like 46XX, although I haven't had my karyotype checked in. And I haven't had mine checked either.
No, I haven't.
But most likely we're 46XX. So that's what you're looking for. You're looking for to be 46XX or for guys to be 46XY. If you have a balanced translocation, it might not show up in the genetic testing of the embryo or in the genetic testing of the products of conception or some other rearrangement that could cause a lot of your eggs or a lot of your sperm and therefore the embryo to have genetic abnormalities that might not be picked up by conventional pre-implantation genetic testing. And
what's a balanced translocation?
Yeah,
I have to keep, because these are new words and new definitions that people don't know yet. So
and there's
define that
stuff
too.
Like balanced translocation, which is a rearrangement, and then there's,
so you can have your 46XX chromosomes, but you have a couple that are rearranged or not in the exact order they're supposed to be. Yeah. And then that can leave us vulnerable to things like miscarriage.
Yeah. And this is not very common. And most balanced translocations would still be picked up on regular PGT. So we are talking
most of it will. Okay, got it.
We're talking about a less than 1% thing, but it is a simple blood test, and most insurances do cover it. So it cannot hurt to talk with your doctor about it if it might provide some reassurance.
Okay, now in the case too of a blighted ovum miscarriage, I mean, we have lots of women in our community, lots of couples in our community, me included, who have had, repeated miscarriages. When you have a blighted ovum pregnancy loss, does that count towards sort of a recurrent pregnancy loss? In other words, like once there's 2 or more, would she still get a
clinical
got it.
pregnancy?
Okay.
As opposed to just a biochemical.
Got it. Okay. So then she, if there was another one, it's unlikely it'll be a blighted ovum miscarriage, right? I mean, that isn't
No,
as common
that's
as
super common. Like
it is
when
super
you see
common.
recurrent miscarriage patients, usually a lot of them have multiple
Have had
blighted
that.
ovum.
Yeah,
So.
got it. Okay. So if there's more than two, that's when recurrent pregnancy loss is warranted, and some of that includes further genetic testing anyway,
Yeah,
right?
yeah.
Okay, great.
Yeah, that's pretty standard for doing the karyotype.
Okay,
Although,
got it.
that's even becoming, that's even, everything we do is a little bit controversial. So
Sure.
I don't want to say that everybody agrees on that, but that's a common time to do it.
So Mel also, when she was 6 weeks, she had 2 sacs that were empty. That's devastating. She went
really
devastating. Really devastating.
But the 2 themselves, having more than 1 sac predisposes the whole pregnancy to miscarriage, even if they're perfectly genetically normal.
Wow.
It's like just a stressful situation to have 2 sacs in 1 year.
Sydney Chick, Sydney, I believe that you're currently pregnant, right? You've been on our talks a few times, so she's definitely experiencing constant nausea, which could be the hyper. How do we say that word, Serena?
Hyperemesis gravidarum.
Yeah, that one.
But that's like really like seriously barfing your head off all the time.
Yeah, she's been throwing up for 5 days straight.
Throwing up. Oh, I
Yeah.
thought you said nausea. Okay.
Yeah, no, throwing up. I just didn't want to.
Okay.
I just didn't want to give away too much information.
You need to call the doctor
she's
now.
8 weeks. Yeah, you need to.
You got to call the doctor now because you need some medicine
and some fluids
to get dehydrated.
Yeah. We need a lot of fluids in there to support the placenta, to support the health of the pregnancy.
And there's plenty of safe medicines that you can take.
Yeah, she said that she was taking tablets, but it comes up. So yeah, I think you need to get maybe an IV, like with an IV with it is better, so it won't come up.
Or suppositories.
Yeah, exactly. There's lots of versions. Yeah, but Sydney, please take care of yourself. Call now. Hop off this and call now. Amy has been trying to conceive for 3 years. She did have 1 pregnancy loss. We're very sorry to hear that, Amy. These are the hardest for us to hear. Low sperm count for the hubs. She's fine. So she did have, which, as we learned, once you start opening your mouth, right, you hear so frequently how other women have gone through miscarriage too. Yeah. No infertility. I mean, my mother had, birthed 5 babies, and she had a miscarriage between me and my younger brother. And, it's very common. She's been through 3 IUIs. They all failed, was told IVF is the next step. Certainly, if it's low sperm count, depending on how low, IUIs, we wouldn't expect IUIs to have a very high success rate in that scenario, right?
Low sperm count tends to make that already kind of low pregnancy rate
even lower. So IVF would certainly be warranted because, at least some, like Serena's team could take the 1 egg and inject just 1 sperm. You just need 1 good one, right? So, but given the fact, maybe because she had the miscarriage, you karyotyping because, like you said, it's usually covered by insurance.
Just 1 miscarriage and everything else normal. It's probably overkill to do a karyotype, but it can't hurt. Can't hurt to talk to the doctor about it.
Yeah, Sydney, there's usually not a correlation between the health of the baby and throwing up that much. But which is why we're just saying call your doctor, get in so that you can.
In fact, usually it's a healthy pregnancy. It's just like overkill.
Yeah, exactly.
Hormones. But if you get sick and dehydrated, that will affect the pregnancy.
That can affect exactly. Yeah. So that's why we want you to go take care of that.
Yeah.
Oh, and then Mel followed up. She said 1 week later. So 1 week they didn't see anything in the sacs and they thought it was bloated over. But 1 week later, both of the fetuses were there.
Wow.
Yeah, and she did have. She said,
twins are slow to develop, so
they are okay.
Twins, like sometimes you don't see the fetus as quickly as you do when there's just one. That's delay is very common on ultrasound with twins.
Okay, that's good to know too. Somebody that I know, both of her embryos took 2, so she was surprised on this weekend when there was 2.
Good surprise.
Yeah, it was a good surprise. She's ecstatic. Yes. Yeah. All right. So a couple of other questions that people asked. Are there higher risks of genetic disorders with IVF or ICSI? Such a good question.
Such a good question. Theoretically with ICSI, people think there might be a small, slightly increased risk of sex chromosome abnormalities that we see with X or Y. but it's a little confusing because most people that use ICSI, there's a problem with the sperm, and abnormal sperm may predispose to those abnormalities anyway. So is it the sperm or is it the ICSI? Is it both? We don't really know. In general, the risk of chromosomal abnormalities with IVF or ICSI or PGD or any of these things is minimum, is almost the same as, in Mother Nature.
Why?
Especially if you can control for all these other factors. But the issue is that most people doing IVF do have these risk factors, like miscarriages, like age, things like that.
Right. Now, also let's define ICSI. ICSI is when you just inject one sperm into the egg, just to make sure people know that, just one at a time, boom, like that. But a lot of programs, a lot of programs are doing ICSI as standard. But the way that you just described it, I feel
like that might be a little overly aggressive.
I agree. I kind of have always thought that, but I feel like a lot of programs have really promoted it.
To poke a hole in the egg,
right? Why do it?
You have to poke a hole in the egg.
Exactly.
It's a little much. Yeah.
Right, I agree. Okay, yeah, glad we're on the same page. Oh, Mel, that's great. Mel's been updating me on her story. She gave birth to baby A. So, yeah, she ended up giving birth to baby A. So that's really exciting, Mel. Thank you for that update. I was getting concerned because I wasn't totally following this story completely. So here's another really good question. Is sperm morphology genetic? So somebody
sperm morphology.
Yeah.
I don't know anything about sperm morphology, except that it seems like everybody has bad sperm morphology. Okay, so the big thing is like when somebody tells you your sperm morphology is 4%, don't freak out because it's not out of 100%. It's out of 5%. So if you're 5%, you're normal.
Okay.
So, okay, and so 4% is, a little bit off. 3% is a little bit off. 2%, and this is not for just one semen analysis. This is for at least 3 semen analysis, at least 2 weeks apart, each of them. So don't go all cray over just one semen analysis. You do need to have a repeat. You need to see the primary care doctor. I think there is some evidence that, the low morphology could be related to stress and inflammation, like just our lifestyle, like you're not sleeping enough. You're eating too much sugar. You're smoking.
Environmental toxins.
You're using marijuana. This past week I've had so many patients that are vaping, and a lot of husbands that are vaping. And don't you guys remember all those deaths we heard about early in the year?
Right.
Unexplained
teenagers.
Death because your lungs were melting from the vaping.
Right.
Don't vape.
Don't vape. Don't vape.
So I want you to stop smoking. I want you to cut back on drinking. I want you to eat more vegetables. I want you to get exercise. I want you to get 7 to 8 hours of sleep at night. I want you to turn on your blue light filters, even when you're watching Instagram Live with us.
I added blue light filters to my glasses. Yes.
Yeah, 12 to 16 hours a day, please.
Yeah.
And try to get 30 minutes a day of outdoor light. You need to take care of yourself. And if you take care of yourself, your sperm, I think, will be better or more functional. Now, we just don't understand morphology that well. It's very easy to understand it when it's in the context of very low sperm counts, because everything looks bad with a low sperm count. Something is wrong with the engine. But when everything else is perfect and your morphology is low, we're not really sure what to do. But I would say, healthy lifestyle, take some vitamins, go see the doctor. I think there's no downside to that.
Right. I think we're going to wrap up with just one final question. Is it a good idea to test genetics even if you're young? I think that is a very helpful question.
That's a great question, and that brings up this whole, kind of rabbit hole of genetics. Yes, I think so, because most children that are born with severe genetic diseases from silent genes like cystic fibrosis and spinal muscular atrophy, really, really difficult, deadly diseases, are born to people who have no family history and no ethnic risk factor. And that doesn't matter about your age. If you're thinking about getting pregnant with somebody, you should know, do you guys have any risk factors? Are 2 of you carrying mutant genes which don't have any impact upon you at all, but when put together in a baby could really be devastating for that child? and you can, and knowing about that ahead of time gives you more options. Then you can plan, you can test, you can treat, you can think about doing IVF with genetic testing to transfer an embryo without those genes. So there's a lot of power that this information can give you, and age does not impact that.
That's right. That's really important, you know, for everybody to understand, is that when we advocate for things like carrier screening, and what Serena was describing is called carrier screening. And that's something that, you know, you can use IVF to pick embryos that are not genetically impacted by things like cystic fibrosis or even the BRCA gene. So
and
we're
this
just
is different than testing the embryos.
yes,
And
exactly.
It's different than Ancestry.com and 23andMe.
Exactly.
They all have different purposes.
Even
all genetic tests.
That's right. Even the genetic tests that we created, we worked with Illumina, the largest genetic testing company. We created a panel just to look at infertility risk markers and the comorbidities, right? So we have a PCOS panel, and it's really meant to just empower people to feel kind of autonomy around the lifestyle choices that you can still employ to help optimize your fertility. Dante, we're almost done. That's my little one interrupting.
Another use of genetic information and genetic testing.
Exactly. It's to optimize wellness.
Yeah.
Totally.
So that's a completely different area, but it's
exactly
still testing.
It's still genetic testing. So, you know, we have 3 billion variants, or 3 billion, you know, things that you can look at in your DNA, each and every one of us. And so there are lots of different uses for it. What we're, you know, discussing today is really that use case for you to understand kind of your own carrier screening. And then, of course, your partners, and karyotyping is a different one that we have brought up, and we're going to give you all these like links and everything so you guys have a deeper understanding if you need it or not. And then, of course, if you do find something, you can either do PGTA, which can look at the chromosomal normality of embryos or not, and there's PGD, but what do they call PGD now? What's the PG? Is it PGTM? Yeah, PGTM for when you're
mutations.
For mutation, for when you're selecting an embryo that doesn't have the cystic fibrosis or doesn't have BRCA gene. So you're welcome, Hey Moms, for all the info. Sydney Chick, what we're saying is, yes, your baby is probably okay, even though you've been that sick. If you get dehydrated, then that could hurt the pregnancy. That's why we want you to hop off of this and call your doctor, so that your doctor knows that you've been sick for 5 days in a row of your pregnancy, because you need probably some intravenous anti-nausea meds and hydration.
Yeah, you need to hydrate.
Which we're huge proponents of hydration anyway during pregnancy. Okay, perfect, everyone. Well, you know, this is the beginning of a lot of information on genetics. Okay, so keep bringing your questions to us. We didn't even get to half of them.
For all these amazing questions that you're sending us. Thank you.
Yes, exactly. Keep them coming, and we will pop back on next week, same time, same place, to say hello and talk answer more questions. That's what we're here for. We love being with you. Thank you all for sharing your stories with us. And as always, you can also ask all these medical questions on the Fertility Answers app, both iOS and Android. And we're so grateful to just be a part of your journey, however brief we might get to be in your life. We're so grateful for the chance to be in it. Thanks, everybody. We'll see you next week.
Bye.